Hello everyone, in this video we are going to discuss about chronic bronchitis. So by definition, chronic bronchitis is whenever there is productive cough for more than or equal to 3 months in 2 consecutive years, it is called as chronic bronchitis. If it is a form of COPD, that is chronic obstructive pulmonary disease. COPD consists of two things, that is chronic bronchitis and emphysema. So it is a part of COPD. Next, the chronic cough in chronic bronchitis is because of due to constant irritation and inflammation of the airways. The etiology of chronic bronchitis is smoking, which is the most common cause, because smoking causes inflammation of the bronchial lining, which further increases the mucus production. Also, air pollution, recurrent infections and occupation exposure is also a risk factor for chronic bronchitis. Next is pathology. The main pathology is the airway inflammation. There will be hypertrophy and hyperplasia of the mucus glands. And the most important thing is Reed's index, which is more than 50%, is indicative of chronic bronchitis. Reed index is nothing but it is a thickness of mucus gland by the total bronchial wall thickness. In this picture we can see C to D is the thickness of the mucus glands by total bronchial wall thickness is A to B. So CD by AB, if it is more than 50%, then it is indicative of chronic bronchitis. Next is goblet cell hyperplasia, and chronic airway inflammation and fibrosis is seen in chronic bronchitis with narrowed airways because of mucus plugging. So in this picture we can see normal bronchus and chronic bronchitis. In chronic bronchitis there is narrowing of the airways and there is increased mucus plugging with smooth muscle hypertrophy, and inflammation is increased, and also there is increase in the mucus glands. Next is symptoms. There is chronic productive cough because of constant irritation and inflammation of airways, wheezing because of narrowed airways and plugging of the mucus, and coarse crackles are heard, also called as rhonchi. Next, dyspnea on exertion is seen, which is later in onset, and frequent respiratory infections are seen because there is impaired mucociliary clearance. So it is also called as blue bloaters because there is cyanosis because of hypoxia. So the skin and the lips look bluish. The patient will be obese because of decrease in the physical activity, and also there will be edematous appearance. And because of this hypoxia, there will be pulmonary constriction, which will further cause with long-standing pulmonary constriction will cause right heart failure, that is cor pulmonale, and this will lead to edematous appearance. Pathophysiology is there is mucus plugging with inflammation of the bronchi, which is causing airway obstruction. There will be ventilation perfusion mismatch because there is decrease in the ventilation because of this mucus plugs, causing hypoxia and hypercapnia. And because of this hypoxia, there is pulmonary vasoconstriction leading to right heart failure, also called as cor pulmonale. The complications are right heart failure, cor pulmonale, and recurrent infections because of decreased mucociliary clearance, and also there is progressive respiratory failure. On chest X-ray, we can see prominent bronchovascular markings with the enlarged heart, and on PFTs, we can see decrease in the FeV1 by FVC ratio, indicative of obstructive disease, and there is normal DLCO because the alveoli are intact. So it is mostly a conducting airway disease. There is no diffusion problem per se. There is in ABG there is hypoxemia and hypercapnia and chronic respiratory acidosis. The treatment is smoking should be stopped, bronchodilators can be given, beta 2 agonists and anticholinergics, and inhalation of the corticosteroids. Corticosteroids will decrease the inflammation. Oxygen therapy can be given for hypoxia. Vaccine should be given to prevent the infections. The influenza and the pneumococcal vaccine should be given, and pulmonary rehabilitation.